my shoulders, knees and toes, my bones, your muse.
Hello, good morning, good afternoon, and good evening to all of you. I'm very happy to introduce this new webinar. As a chairman of the Education Committee of ICRS Society, that I remember you is the International Cartilage Regeneration and Joint Preservation Society. I'm really proud that in this difficult period, we have been able to organize this series of webinars, 7 events that will take us till September, hoping to be back in live meetings in Thessaloniki on October and then in Miami in November. I'm also very pleased to know that we have about 500 registered participants to this event today from 65 countries. As you know, the webinar will be on the innovative one-step scaffold regeneration of the cartilage. With me, I have 2 friends and 2 colleagues from Germany, Justus Gille from Hamburg and Philipp Roessler from Bonn. So we are ready to go. I'll start with an introduction. Before my introduction, as I told you, I want to thank my committee for the great job that has done. And also I want to thank my president, Tom Minas, my vice president, Lisa Kohn, and all the executive board for having permitted to have this success and this organization. So we are ready and we shall start introducing the argument. Ready to go. So as I told you, this afternoon, we're going to speak about the evidence and the innovation for scaffold augmented one-step cartilage repair. So what we are going to speak of will be obviously cartilage defects. I won't bore you much on this. You perfectly know that we can have post-traumatic cartilage defect and degenerative cartilage defect, and obviously that risk to bring to OA development. What we will speak of is clearly the full thickness cartilage defect that from the ICRS Society classification are grade 3 and grade 4 defects, as you can see in the pictures on the right side. Obviously, as cartilage surgeons, we look to regenerate our cartilage. That means that we look to regenerate all the osteochondral unit. That means that we want to repair both the bone and the cartilage level. Why? Because obviously we point to obtain back all the properties, all the mechanical and metabolic properties of the cartilage tissue. That means trying to get back to collagen type 2 and protoglycans and having no fibrous tissue repair, but hyaline cartilage regrowth that has to be perfectly integrated with the healthy cartilage around the defect. Why we look and we love to do one-step cartilage? You know that obviously ACI, the use of chondrocyte, has been for a long time. When Mats in 1994 introduced it together with Lars Peterson, obviously they have convinced us to have very good results, but you know that that type of surgeries require 2 procedures. So first of all, one-step cartilage regeneration has been introduced to avoid 2 surgical procedures, to enhance patients' recovery, to reduce the cost that at least here in Italy were really very important, and also reduce the morbidity consequence of the 2 surgeries and also the surgical risks. And finally, but maybe most importantly for all of us as surgeons, to delay the osteoarthritis development and the need to go for arthroplasty that can be uni or total knee arthroplasties in these cases. But in the last decade, the tissue engineering also came to help us. And this is based on 3 steps: cells, growth factors, and obviously scaffolds. And we obviously are pointing on the use of this scaffold in our one-step surgeries, because obviously this one-step surgeries repair try to enhance the standard microfracture technique to induce the reparative marrow stimulation, and so cover the blood clot with a good matrix that enhances the repair. And through this 3D matrix, allow the MSC's seeding and differentiation. Just to conclude, before giving the word and the talk to Justus, you know that the most well-known procedure based on a scaffold is obviously the Ammic technique, that where you can find in the literature very good results, and Justus will show us also in the very long term at 10 years. I have worked and introduced the addition of adipose stem cell and adipose graft, introducing on the market the Lipoammic technique. And nowadays it's become a very, let's say, a la mode, the use also of minced cartilage graft, and this will be presented by Philips. So I won't lose any more my time, and I immediately will give the word to Justus, that will speak about the results of cartilage or collagen scaffold-based one-step cartilage repair. Please, Justus, come along.
Dear Fabio, it's a great pleasure, and thanks a lot for the introduction. Unfortunately, you first need to give me the presentation rights because you're still in there. Otherwise, it would get a little bit boring, probably without slides.
I'm out. I'm
Fabio,
out.
Stop screen sharing. Okay, you're good.
Here we are.
So once again, thanks a lot for the introduction. And it's really a great pleasure for me to talk about the results of a collagen scaffold-based one-step cartilage repair. And right at the beginning, I want to take the chance to pinpoint to the fact that dealing with cartilage repair, it means dealing with a young patient population which has a lot of years to go. And behind this background, we really need to choose the treatment which is the good one and not the bad one or the ugly one. So looking into the literature, you can see that there's a wide variety of studies out there, and most of them deal about the chondrogenic membrane. They're on the one hand RCT studies, and at the other hand case series studies and case control studies as well. So going a little bit more into detail, you can have a look at the literature, and you see a lot of publications out there. And I just want to focus on a couple of them, which are marked in a blue color. So on the one hand, these are RCT studies. On the other hand, meta-analysis, case series, and one study comparing the mini open versus the the arthroscopic approach. But at the beginning, I will give a short introduction, and I will do that presenting a case of a 19-year-old female. She was suffering from anterior knee pain, especially when she was riding her horse. And as you can see on the MRI, she has a cartilage lesion at the patella. And prior to that, she had an MPFL reconstruction. This is what the surgical steps are. So this is the first arthroscopic view, which shows a cartilage defect at the patella. And after that, oh, it doesn't work. I can show you the single steps, but I will tell you the steps you need to do to perform this Ammic procedure. So after the diagnosis of the cartilage lesions, you need to debride the cartilage defect and remove loose cartilage. You can either do it in an open procedure or you can do it in a mini open procedure. After that, you have to perform a microfracturing as you all know it. and then you have to cut back the template, and after that the membrane to defect size. And the last step is to fix the membrane in the defect. You can either do it with the fibrin glue, or you can do it with sutures, just as you like to do it. The suturing is only possible doing it in an open procedure, but not arthroscopically. And this is at the end of surgery. You can see the membrane is in place. And I asked her 2 years after the surgery if she could send me a video how she's doing, and this is the picture she sent to me. So as I told you, I want to go a little bit more into detail, showing you some studies, and one of the most important studies is published by Foltz in 2017. It is an RCT, AMIC versus microfracture, and after 5 years, what you can see is the microfracturing results, they decline after year 2, marked with a yellow bar. But in comparison to that, the results of the AMIC procedure, they stay stable even in the midterm outcome. Just about the same, another RCT study, AMIC versus the chondrocyte implantation, published 2019. It is a follow-up after 2 years, and there were no significant differences in improvement of the functional outcome scores between the two groups. And what is important to me is that these results were achieved in relatively large degenerative lesions, which with a mean defect size of 5.2 square centimeters. So going away from the RCT studies, focusing now on the meta-analysis, there are 2 meta-analyses out there. One is from the year 2020 by Steinbach. There were all in total 12 studies included, with almost 400 patients with a minimum follow-up of 2 years. And what you can see is that there's a significant improvement in the functional outcome scores in all studies, measured by the Lysholm score and the IKDC, and on the other hand, a significant decline. Just about the same by the study of Kim as well, 2020, comparable results with a significant increase of the functional outcome scores and decrease of the pain measured by the VAS. So what about long-term outcome? I've shown you results up to 5 years by now, and this is a case series studies of 33 patients with a mean defect size of 2.8 square centimeters. And what is important to know in this study is that there is a high rate of concomitant surgery, which was done. For example, osteotomies 27, or meniscus reconstructions. And looking at the results, and I want to pinpoint to the follow-up of almost 10 years, is that there's a significant increase in the functional outcome measured by the Lysholm score, as you can see in the shown bars, and a significant decrease of the pain measured by the VAS. And there were only 2 cases of this, in total 26, who had a revision to arthroplasty in this series. But you should keep in mind that in this series there was a high rate of concomitant surgery. So I want to switch to the study we just published this year of 128 cases without concomitant surgery. So AMIC as a standalone treatment with a mean defect size of 3.4 square centimeters. And as you can see here, for example, looking at the Kuhs score or the Lysholm score, is that you can have a significant increase of the results if you compare the first year results compared to the preoperative values, and these values, they stay stable over time up to 7 years. So in conclusion, again, a significant improvement of the functional outcomes and a decrease of pain. in our group, we compared our results of the AMIC procedure done in a mini open procedure versus an arthroscopic procedure. And as you can see, for example, looking at the Coos score, that there was no significant difference comparing the mini open and the arthroscopic approach. And just about the same for the Lysholm score and the VAS. So in conclusion, the surgical approach didn't have an impact on the functional outcome and decline of the pain. So I want to conclude that, as I've shown you, the AMIC procedure leads to a reliable long and midterm results, pinpointing to the fact that it is a resilient repair tissue which is gained by the AMIC procedure. And you can do the AMIC procedure either arthroscopically or mini opened. It's up to you. The surgical approach does not have an impact on the outcome. Thank you very much.
Thank you very much. Before you move on and you show us one of your beautiful cases, I want to emphasize the fact and invite all the participants to actively get in. We want a very interactive meeting, so please join, question and answer, don't hesitate. And in this case, I want to thank Chao Zong Liu that already started doing his first question. So before going for the case, Justus, please, could you answer the question that asked you, which are the criteria for selecting the patients that receive, in this case, AMIC treatment?
Oh, okay. So in general, it should be a circumscribed cartilage defect. It can be either small or up to large defects. So we were looking at our series with cartilage defects up to 8 square centimeters, where we performed the AMIC procedure. But most of the times the AMIC procedure is done in circumscribed cartilage defects with about 3 to 4 square centimeters. And important is, if necessary, to do concomitant surgeries, for example, patellar realignment. But as I've shown you in our series, is that the AMIC procedure works as a standalone treatment as well if the cases are well selected and do not need concomitant surgery as well.
Thank you very much. Please, all the others, Adriano, Daniel Grande, thank you for staying with us. We'll keep these answers, your questions, and we'll give you the answer following the final presentation. So stay with us. In this time, I go back to Justus. Please give us the show and show us your arthroscopic AMIC case. Thank you.
Okay. Yeah, thank you very much for the introduction. So it's the next step now. I've shown you the results of the study comparing the open procedure versus the arthroscopic procedure. And now I want to take the chance to show you one of my cases done arthroscopically. So it is a case of a 28-year-old male. He did a lot of sports in the past, and then he focused on a business after he got into sports again, and then he was suffering knee pain for about 6 months when I got to know him. Besides that, he had a swelling after sports activity in the knee, but no trauma. So this is what the MRIs looked like. You can see a circumscribed cartilage defect at the medial femoral condyle and some bone marrow edema close to the cartilage defect. During surgery, we saw just about this cartilage defect with some loose cartilage around the defect. And the first step is to debride the cartilage defect and remove the loose cartilage fragments. After that, you need to measure the defect size. For example, you can do it with a probe. And then you have the chondrogenic membrane. It is not possible to use the template in the arthroscopic procedure. And then you have to cut back the membrane to a defect size. When the membrane is wet, it is difficult to divide the two layers. So sometimes it's helpful to mark the top of it. You can double check the size of the membrane again with a probe, and then you should either do a microfracturing or a cold drilling, as you usually do, for example, at the microfracturing or at the Pridey drilling. Again, you should remove some loose cartilage fragments. And then the next step is to bring the membrane into the defect, just as you can see here. And the question is, how can I fix the membrane in the defect? And if you do it arthroscopically, it's only possible to do it with fibrin glue. So this is the fibrin glue, or you can see the needle. And if you start at the top, gravity will take the fibrin glue down. And the next step is, again, to use the probe and get the membrane into the defect so it's flush to the surrounding cartilage. Another important step during surgery is to remove additional fibrin glue, because it sticks to the surrounding soft tissue and may detach the membrane when the knee is bent. So this is at the end of surgery. And the next is that I want to show you the 6-month follow-up MRI, and you see a defect filling of the area, and just a few bone marrow edema close to the reconstructed cartilage. And then I asked him if he could send me a pictures how his knees are doing. So he's back into running, as you can see, and he's back into motocross, and in total he's very happy with the knee. Thank you very much.
Thank you very much, Justus, for the very nice case. So in the meanwhile, while we share back from you to me, Dan Grande, from our great executive board member and historic participant and head of the ICRS Society, is asking you if you have any analysis of the biopsy of the quality of the repaired cartilage.
No, I don't have any histology, and the reason is very easy. Because we were we did not have the opportunity to do it in a study due to our ethical review board. And there was only one case where I had the chance to do an arthroscopy, and that is the one I just showed you in the talk, where you could see the defect filling, but we did not take a histology at that time. But there are histology studies done on sheep and horses, so animal studies.
Thank you very much. So continue asking, and also Philip and Justus, please help me in the question and answer. So we'll keep everything live. Now it's my time to go back and give you just an idea of what the options can be when you want to do a biologic enhancement of one-step cartilage repairs. So as I was saying, and as you've just seen, the AMIC technique is certainly the most studied and the most published technique, one-step technique. You can see, and you have just seen the good results also in the long-term follow-up. This same technique has had an extended use to other joints, maybe ankle and hip, thanks to the my friend Fontana. As you also have thanked Justus, he has shown the arthroscopic technique. But as everything in medicine, we always try to improve our results. And trying to improve the results of the AMIC technique, several colleagues have thought to try to do some augmentation of this procedure. The first augmentation has been the use of PRP, that as I'll show you in the literature, you will find 2 different reports. Then we have had the use of bone marrow concentrate and adipose stem cells. So as I was telling you, the first technique, the first augmentation was introduced by previous HRS president Thelander in 2010. He defined it as the AMIC plus technique, and you can see the diagram of the technique up in your right side. He used to have as a scaffold the collagen 1-free scaffold, Chondrogenic, produced by the Gastric Society, and he enriched that type of scaffold using a platelet-rich plasma gel. The paper he published was on 5 patellar defect patients, and he could share the fact that he had a clinical improvement. He also showed a very good improvement on the MRIs through the MOCAR improvement, but he also had the backside of finding some intralesional osteophytes. So he concluded saying that the PRP gel did not seem to have obvious beneficial effects on improving the standard technique. Just some years after, Matthias Steinbach introduced in 2014 the matrix-associated chondroplastic, what he called the MAC technique, where the adjunct was PRP and bone marrow concentrate. Why? Because he looked to enhance the number of growth factor and of MSC cells. The technique was just debridement of the bed of the defect with no injury to the subchondral bone. In this case, the collagen, the same collagen membrane, was soaked with PRP, and as you see in the images, the BMAC was then injected into the defect. The paper has just introduced the technique, and there was no following papers on the, let's say, short-term or long-term results. As I told you, obviously what came over was the idea of using bone marrow aspirate and concentrate augmented matrix chondroplasty. The first one, always in 2014, has been my dear friend Alberto Gobi, where he published his first results in the use of the collagen 1-free scaffold plus BMAC in 25 patients with a 3-year follow-up. So already a good short-term follow-up. And a very large, I should comment, size of the lesion, because this average lesion was 8.3 square centimeters. In the conclusion, Alberto was able to state that patients under 45 years were with smaller and single lesion, not bipolar, but single lesion, had the better outcomes. That MRI results showed a complete filling of the defect in about 80% of the cases, and most of the biopsies that he was able to have showed a hyaline-like cartilage tissue repair. Just a couple of years ago, Laura De Girolamo also published a paper together with Piero Volpi here in Italy on the use of the chondroguide scaffold and comparing the standard AMIC versus AMIC plus BMAC in 24 patients with standard AMIC, 24 patients with enhanced AMIC. In this case, the size of the lesion was smaller. You can see in the first group was 3.8 square centimeters. In the second one, in the enhanced AMIC, was 3.4 square centimeters. In the conclusion, my friends said that the two techniques are effective treatments for focal lesion with effects that are good and last up to 9 years in the follow-up. But the AMIC Plus allows for faster recovery. And so they concluded that it was indicated in patients that wish to have a prompt return to activities and possibly also some athletic activity. And this is opening and partially answering to the question from Camilla from Brazil. And we will go back to that, Camilla, in some minutes. I just want to show you, I'm also used, obviously, the bone MAC augmented technique. Is this just to show you how quickly you can do it with a power drill. It's just maybe less than 5 minutes. You introduce your cannula, then you introduce, as you can see, your plunger. At this point, you are able to slowly withdraw the bone marrow. This is a case from the tibia, but obviously in most cases, I'm doing it from the iliac crest. You will have 2 syringes with a total of 60 mLs of bone marrow, and then you will put in your centrifuge and you will be able to use for your repair. This just to show you some images, the effect of the patella, debridement, also with a shaver. as you can see, you size as you saw with Justus, then microfracture, cut of the membrane, soaking the membrane in the bone marrow concentrate, and finally the application. I don't want to lose time because I'm going to speak deeply about the adipose tissue. So here we are. The other idea is the use of augmenting the standard AMIC with the use of adipose tissue stem cells and adipose tissue graft. Why? Because if you go and look in the recent literature, many papers, and including this review in 2017, demonstrated that the results of cartilage repair were improved by the use of scaffold, and were still much more improved if this scaffold was added with adipose tissue and adipose stem cell. So from there, the idea of using of creating what I call the Lipoammic technique, that obviously depends on the use of a good scaffold, in this case the collagen 1-free chondroguide, and a good system to withdraw the adipose tissue, in this case the lipogenic microfragmented system. Quickly, you go for a Lipo aspiration. You just, as you can see, you have a needle opening in the adipose tissue of the abdomen. Then you can introduce your cannula, slightly increasing the opening of your needle. And at that point, you are able to introduce the Klein solution that will distend the adipose tissue of subcutaneous abdomen. You see at the end, you move up and down the cannula just to facilitate the withdrawal of the adipose tissue. And there you see it in the left. You can see the Lipo aspiration. You just take out something between 60 and 100 ml. Then you are able to put it in the Lipogem system and just be able to discard all the oil and all the debris, and have, as you can see in the center in the lower slide, your tissue graft with your tissue adipose stem cell ready to be used. How do you use it? In this way. In this case, you have already the defect with the debridement and the microfracture. I'm just adding some stem cells. As you can see, in the meanwhile, the collagen membrane is soaked in the adipose tissue graft, and I'll keep it there for about 10-15 minutes. Then I'm able to apply the membrane on the cartilage defect very smoothly. I'm adding then some more cells and some more adipose tissue, and I'm gonna fix this with, as you'll see, here we are, with some fibrin glue, on top of which I love to put some more cells and some more adipose tissue graft. And then this will be the vision you find, and obviously no idea, no sign of the previous cartilage defect. Just to say you, this is the experience. I'm showing the 2 years results. I'm publishing the 5 years results, that which I can assure you the scores are even better of the two. So my experience is speedy good from already the 6-month first follow-up, and is still good, very good at 5 years follow-up. But I don't want to lose any time, and I was just to introduce my friend Philip, who will talk about the Minced cartilage repair. As you can see, it has been first described by Albrecht in 1993, and its use depends on the use of cartilage fragments plus fibrin glue. During the last year, several techniques have been proposed, from the KAIS to the ADDT, and the use also of PRGF, also by Steinbach, or allograft with the Minced juvenile allograft technique, mostly used in patellar and trochlear cases. But more recently, the idea of covering the defect with the collagen scaffold, a collagen membrane, has been emphasized and proposed to protect the repair from the shear forces and the dislocation of the repair, to guarantee the primary stability and to stimulate chondrogenesis. But at this point, I obviously want to leave the word to my friend Philip and introduce him I'm sorry, I got it wrong. I'm sorry, I'll go back. It's my turn to go on and show you just my case of lipoammic. Sorry, I'll be back there.
Fabio, maybe we can take.
Yeah, in the meanwhile, you can go for some maybe questions if you find them and you answer them.
Yeah, maybe we can take the chance, because there's one question which suits exactly in that what you were talking about. It is the question, what is the indication for the AMIC plus, or the question exactly is, do you think elite athletes should receive a different treatment? So do you think athletes need more than AMIC?
Well, that's very interesting. From my side, as I showed you, the lipoammic enhances the timing, the first timing of the repairs. So patients are feeling better already in the first post-op regimen. And this maybe certainly gives us the idea that it could be a good idea to propose it also in elite sports guys. One fact certainly that I would suggest is certainly that all the one-step cartilage procedures are certainly better indicated for athletes, because obviously you are less invasive and you are certainly a little bit faster in also the rehabilitation. I think that one of the topics we should discuss at the end is also the post-op regimen. What you, Justus and Philip, also come in, what do you comment to this question from Camilla?
I mean, you're certainly right that AMIC as a one-step procedure poses a good viable option for athletes, but in the end, it's all off-season surgery, right? So you need a certain maturity of a graft over time to be in a full weight bearing position, to be full pain reduction. So this takes time. So there is not really a one-stop shop opportunity we have right now that gets people back on track within 4 weeks. So this is off-season. It may be suitable for athletes, even for elite athletes, but with a little bit of time to achieve maturity of whatever regenerative tissue we create.
I do agree. Justus, any comment before I go on?
No, I think I would have just answered the question just like Philip did.
Perfect. So I'll briefly give you my lipoammic case presentation. Obviously, I won't show you anymore the steps of the technique. I was going, but I don't know why I'm stopped there. That's it. So this is the case of a 43-year-old man, as you can see, with a large trochlear defect, 2.3 for 2 square centimeters. As you can see, nothing particular in the physical exam, no axial deformity, no ligament instability. So this was just an arthroscopy with a medial partial meniscectomy where this lesion was found. This very quickly, as you can see, are some pictures of the steps I showed you in the detail before. As you can see in the lower images, you can see already the first MRI post-op at 6 months and 12 months post-op. This is the 24 months. I was lucky also, I should say, to have the second look. And as you can see, I found a very good repair tissue integration and regrowth.
Fabio?
Yes?
We cannot see your case, unfortunately.
Oh, sorry, I continue
it's very interesting to listen what you're saying, but...
Can you see it now?
Yes.
So I'll just go back maybe. Okay, this is a trochlear case, perfect. As I was telling you, 6 months and 12 months MRI post-op. And here we are, as I was telling you, the second look arthroscopic view of the defect with a good integration of the tissue. And as also you can see a very good histologic result at that time. But interestingly, at 5 years post-op, I've had the chance also to do this T2 mapping that, as you can see in the lower slides, show a very good collagen recruitment and regrowth with a complete defect filling. But as you know, I love to be clear and to check whatever the companies say. So I went also analyzing what was in our adipose tissue graft. And I was able to see that really we were able to identify two main cell populations, as you can see, MSCs and endothelial cells. But very interestingly, there was a great increase in the endothelial cell population with the LipoGem system lipoaspirate. And also important was the fact that we could be able to see really the niche preservation. So the cells are perfectly normal, perfectly conserved. This is just a FACT scan analysis that confirmed the fact that these are MSCs with good receptor positivity. So this was just the case I want to show you. At this point, I'll go back and please invite Philip to present his great experience on minced cartilage with collagen scaffold one-step repair. Yes, Philip, we can see you.
Can you see my slides?
Perfectly, go on.
Super. Thank you, Fabio, for the introduction. If we talk about minced cartilage, we need to talk about the history of minced cartilage because honestly, there is still today, although the technique is known for quite some time, but has a renaissance in recent years, not much evidence out there. It was first described by the German colleague Albrecht in '83, and he did a comparative animal model in rabbits. And as you can see on the upper right, he treated full thickness osteochondral lesions with cartilage fragments and fibrin glue. He achieved viable chondrocyte proliferation as well as a good defect reconstruction, as you can see already after 10 weeks in this histologic slide of the subchondral bone and a hyaline cartilage formation. It's important to know that this is more of a juvenile cartilage fragmented procedure, so it's not really comparable to what we know as minced cartilage of an adult cartilage fragment today. He called it a second adolescence of hyaline cartilage due to nutrient and oxygen supply from cancellous vessels. Then, for a couple of years, almost for more than 3 decades, nothing happened. And then it's important to talk about the only, until today, the only randomized controlled trial that is out there, the KAIS system by Brian Cole and colleagues from Chicago. They did a comparative clinical study, level 2, microfracture against a minced cartilage type filled in a synthetic cage mixed with PDS pins. Fixed, sorry. So it was the first use of a special device to harvest and mince cartilage and perform this minced cartilage-like procedure. And as you can see in the MRI controls on the upper right, they received good results, good MRI outcomes, even after 2 years of follow-up, good clinical results, and deemed the KAIS system a safe and feasible and effective method in treating full-thickness cartilage defects. However, like it's in the market always for many, many years, the system was discontinued by the company some years ago. Then we have the ARTT technique, which means autologous dual tissue transplantation. This is a clinical case series, so it's only level 4, 8 cases of osteochondritis dissecans in this case, which is a disease that also affects the subchondral bone and creates some sort of subchondral pathology there. They have a short-term outcome of clinical and MRI results with bony defects nearly filled with autologous bone and cartilage defects filled with the minced cartilage in a sandwich-like technique. The treatment of these osteochondritis dissecans lesions with the ARTT resulted in good subchondral bone restoration, and a good cartilage repair, as you can see in the post-op MRI 1 year out. Today, there are no further follow-up publications by the group, unfortunately. Then, of course, we have the Lenovo system. We have particulated juvenile cartilage allografts. This is a product harvested by donors. It has a 10 times higher chondrocyte density than adult cartilage has, so it's more of a comparison to what Albrecht did back in the day. It is less differentiated and thus significantly more efficient in producing hyaline cartilage and adult chondrocyte differentiation. Since it is non-damaged cartilage and there are no arthritic changes, this is possibly the good selection we have to achieve the best regenerative results, but it comes with a price. So the impact of shelf life and donor age is still unclear. We don't know that, although there are pretty much results out there. There are good functional outcome and histological repair quality in this case series. We have some more case series by Bona, by Farr, by Grave, all with pretty much the same results, more to come. In total, it's more than 100 cases in the case series so far. So results are pretty solid and they are pretty much comparable if we talk about PROMs and if we talk about functional outcomes. Then if we talk about minced cartilage, we have this clinical case series by Cougat and colleagues. It's a level 4 evidence study, 15 cases of full osteochondral defects, as you can see on the upper right. We have short-term outcomes, mean 16 months follow-up, clinical and MRI outcomes. This is a truly minced cartilage created from the debrided defect with a PRGF formulation to fix the cartilage fragments in the defect. It's a combination of an arthroscopic and a mini-open approach to first harvest the cartilage, then mince it, and then to openly reduce it into the defect and fix it there. They showed a significant improvement in all clinical functional scores reported, and notably the MOCAD score is back to 70 from 100 after the follow-up time. Then there is another case series by Massen et al. This is the group of Gian Salzman and colleagues. They have so far the most extended case series with 27 cases, and they also reported the combination of minced cartilage with a collagen membrane here, the chondrogenic membrane, as you can see on the pictures to the right. This was used in 19 cases. And the authors noted that it's especially suited in areas where we have a lot of shear stresses, a lot of high contact forces. So maybe possibly for the trochlea and the patella in particular, because their shear forces are much higher in mid-flexion. Also here, we have significant improvement in joint function and pain reduction over time. This is a 2-year follow-up. So all in all, there is only short-term evidence for the minced cartilage we use and know today. We have some experimental findings of note, an ex vivo model of cell outgrowth from cartilage fragments by Liu et al. No cell expansion as in cartilage biopsies for Macy was shown, but a cell outgrowth, cell migration, and cell differentiation. We have an in vitro model of fragment size related ECM production, and the authors were able to show that the ECM amount and quality depend on fragment size really and the preparation method. So Bonazia and colleagues showed that smaller fragments, 1 millimeter to 0.3 millimeter, perform better than larger fragments. So we can facilitate outgrowth and ECM generation by fragmenting cartilage in smaller sizes. Then there is an in vitro model of a special mincing device to prepare the cartilage by Levinson et al. And they showed that fragments are a source of chondrogenic differentiation. Fibrin glue and collagen hydrogels are sufficient as scaffolds to promote cell outgrowth, migration, and differentiation. cell viability and matrix deposition are proven after 28 days. So this is a combination of minced cartilage together with a cell-free preparation of a matrix. So in summary, the pros and cons of minced cartilage as we can take them away today. The cons, of course, are limited clinical evidence for minced cartilage so far. This refers to a low case number in total and the short-term follow-up available only. Most studies are non-comparative or uncontrolled case series, as it is the case for most new techniques or devices, with the exception of the KAIS RCT. There is so far no clearly defined minimum or maximum defect size because we're missing, of course, in human and even in animals where there are small numbers only, good histological analyses. We don't know the contraindications so far, so it's a pretty much open technique to use, I would suggest, in concurrence, in direct comparison to, for example, MACI. The exact interaction with other autologous blood products, for example, is unknown. So this is still another problem. So evidence, all in all, is still too low to make a big statement here. The pros, of course, are it's a single-stage, reproducible, and very simple procedure. Most basic form can be done without any further gadgets. It's low cost or comparably low cost compared to other devices. You have the fibrin glue for the Minced technique, and you have the cost for a membrane for a matrix if you choose to go the way of covering the minced cartilage with, for example, a Chondrogenic membrane. And a good thing, at least in Germany, this is very important, there is still no regulation, so you can perform the minced cartilage technique without any impediments from politics or any regulative bodies. So why should we use, to get back to this, an additional membrane? Additive chondrogenic effect has been proven for chondrogite in many, many studies, not only to mention Dickut and colleagues where they investigated the chondrogite membrane in the ankle. The membrane may protect the minced cartilage, as I said, from shear forces and dislocations, especially in patella and trochlear defects where there are high shear forces. But good biomechanical studies are still to be undertaken and still need to prove these hypotheses. The membrane may provide primary stability to the construct and, comparable to what is reported about first generation ACI, act as a bioreactor to create a closed system for the minced cartilage within a contained defect that is surrounded by synovial fluid in a semi-permeable fashion. So there can be exchange through the matrix, through the membrane, and the minced cartilage either way stays protected from the outside. Then I will immediately get to my case presentation of minced cartilage with a chondrogite membrane. In this case, we have a 25-year-old male cook. He's an ambitious soccer and field hockey player, so he does a lot of full contact pivoting sports. Clinical examination preoperatively shows weight-bearing pain on the medial side of the left knee, aggravation under higher loads, especially during running, jumps and axial compression forces nearly impossible lately, symptom duration for far more than 9 months, with a free range of motion, physiological lag axis, no ligamentous instability. So the preconditions are pretty good in this case. MRI investigations show a suspected old osteochondritis dissecans, as I showed for the ARTT technique in the previous case series, with a minimal subchondral bone edema with intact subchondral lamella or subchondral sclerosis. We show the only slight edema, but radiologists at our department were not able to state if the subchondral bone was really damaged in all slides. Intraoperatively, defect evaluation showed a smooth sclerosis, DD calcified layer of the defect bed, no bony defect or erosion, cancellous bone was not visible. A blunt cartilage defect shoulders without delamination to further have a larger defect as we'd expected, and reduced loose bony body in the notch, which was not identified in the MRI previously. So we confirmed the diagnosis of an old stage 4 osteochondritis dissecans. So what did we do? First of all, we debrided the defect shoulders to ensure good defect containment and obtain a small amount of viable cartilage, because obviously we could not take this one from the loose body because it was like destroyed, mainly and most soft tissue. It is viably important to remove the calcified layer with a curette or high-speed burr if you deem. This should be water-cooled if you do it in an open fashion until slight petechial bleeding occurs to ensure a recruitment of MSCs from the subchondral bone. Templating of the ready prepared defect, mincing of the obtained cartilage to fragment sizes around 0.5 millimeters. You can do this in a very easy fashion with a 10 scalpel blade. Optional use of a special device for debridement, as you have them on the market, is possible for collecting and mincing cartilage, but it's not needed. You can fill the defect with the minced cartilage and fibrin glue, or you can do it the other way around, as it is shown in this slide. If you use the minced fragments and plate them on the membrane, cover them with the fibrin glue to create what I call a composite graft, and place this one in the defect. Personally, I do it the other way around because I feel that I can create a much more contained defect and avoid understuffing of the defect to achieve a far too low niveau of the defect reconstruction, and I can control pretty well how many fragments I need to put in the defect and how much cartilage, how much fibrin glue needs to go in there before I cover it with the chondrogyte membrane. Personally, I also prefer to close everything up with fibrin glue to the edges and then add additive PDS sutures to fix the membrane in place to ensure additional stability and to even more prevent shear forces from dislocating the membrane. As you can see here, in the only 3-month post-op MRIs, we obtained a full defect filling and a good femorotibial joint containment. We have only minimal subchondral bone edema. There is almost no comparison of the edema if you compare it to the first case, so that did not change much. So we have a minimal hypertrophy, especially in the sagittal plane, and the MOCAT score, sincerely, is 80/100. Clinical examination, 3-month post-op, showed no more pain during upright standing or walking, free range of motion, rehab process went smoothly, no more impairment during work. He was advised to return to competitive full contact pivoting activities as he did before, only 6 months post-operatively. This may also add to what I said about elite athletes. You need to allow a little bit of time for the whole situation to get mature. You can see that there is some degree of maturity because there is already a cartilage-like resemblance in the MRI. Unfortunately, I don't have T2 mapping here with me to show that there is also a good perfusion, but it still needs to differentiate more to have full contact forces like you achieve them in pivoting sports. So light and medium training like running and cycling to ensure free range of motion and encourage muscle strengthening and stability is possible, but I would advise you to at least have them out for 6 months referred to pivoting sports. Thank you.
Thank you very much, Philip. Great presentation, great case. Let's say that this Italian-German collaboration is giving great results. We are perfectly on time. So we have 30 minutes of discussion, and we are also full of questions. So I will start introducing the questions. I think we can start from the ones that are typically of the surgical step. First question we have from Adriana Almeida is, are we performing microfracture or nanofracture associated with the membrane? So I will, let's say this way, I'll start with Justus' answer, then Philip and I'll give mine for last. So please, Justus.
So it's my answer is pretty short, because I prefer not to do the microfracturing. I went away from microfracturing. I'm not into nanofracturing. I'm mainly into cold drilling. So I do it with a 1.0 or 1.2 K wire, and I do the cold drilling. So I'm not too much into microfracture or nanofracturing.
So let's say that you have moved away from the standard AMIC technique. That's okay.
Yeah.
What do you say, Philip?
If I perform AMIC procedure, I also go for cold drilling, because for me, it's the most suitable and most elegant way to not damage the subchondral bone more than I need to. Because I found that if I use the old chondropicks that are far thicker than my 0.1 drill, it's always with a risk of delamination of the subchondral bone, especially if you perform it in regions when you cannot achieve a completely sagittal approach. So cold drilling is the way for me to go.
So both of you are not using any more holes, but you are doing both of you drillings.
Yes.
Is that correct?
Yeah, that's correct.
So can we confirm the message that maybe the majority of us, also for some biologic papers that have come out, have moved to drilling and left the standard old technique away? Do you agree? Can we conclude like that?
Of
Just
course.
to give some messages?
Yeah, of course. I mean, this has been around for quite some time. There is this epochal paper by Ken, for example, where they compared the drilling against the classical microfracture, and drilling has proven to be beneficial as long as you stick to water cooling. It needs to be cool enough, then drilling is no problem, because it creates a better venting, doesn't close Hovers channels. So for me, it's a much more elegant technique.
I absolutely agree with you. And remaining on the technique, they're asking us if we believe in the use just of fibrin glue or the use also of stitches, sutures. I'm believing mostly on fibrin glue at just rare cases where I feel that the membrane could not be so stable. I'll go for some stitches. So let's go the other round. Philip, what do you do?
As I showed you, if I perform it in an open fashion, of course, I use stitches because I learned it that way. There is not much evidence telling us we need to use stitches, but I feel much more comfortable. And to be honest with you, most defects we treat, especially the larger ones, they are not 100% contained, right? So you have one shoulder that is a little bit shallower. So I feel more comfortable by placing like 6 or 7 stitches there. It doesn't hurt the patient, and it gives me the extra safety I need to sleep well at night. So this is some sort of a belief. I think we cannot prove this by literature.
Justus, what do you think? What do you do?
So actually, I do about 99% of my AMIC cases, I do arthroscopically. So I do 99% with fibrin glue and no sutures. But it's just the surgical approach which makes me just use the fibrin glue and not the sutures.
Okay, but I think it's also a factor of experience. All of us, when we finish applying the membrane, we just go for some raw movements, and you are quite sure that what you have done is fixed. You can see it with your eyes, both arthroscopically and most obviously if you do an open. Do you agree with that?
Absolutely.
Okay, now we have a second question for our second vice president, my dear friend Daniel Grande. He's asking, what is the primary cell source for the repair? Marrow versus synovial membrane, fat pad? Well, I won't answer that because obviously it is simple to understand that I'm also using adipose stem cells. So the two of you, Justus, what do you do? What do you think? It's the marrow coming from the microfracture, but you're not doing any more nano or microfracture. So where do you pick up the cells?
But actually, I would be very interested in your answer as well. So, but I go for the cells from the bone marrow by drilling.
Okay, Philip.
Unfortunately, I cannot show you results of a study I undertook 2 years ago. We are finishing up this one right now, so it will soon be published. We investigated another cell-free cartilage repair system composed out of collagen, one collagen source, and we asked ourselves the same questions that is asked in almost every conference you attend. And what we did is we created an in vitro setting where we colonized the scaffold with various cell sources, with bone marrow derived MSCs, with fat-derived MSCs and synovial-derived MSCs, and all those different cell sources colonized the construct equally well. The synovial-derived MSCs maybe had a bit better migration into the scaffold, but in the end, there was a good comparison between the three of them. So what I personally believe in the bioreactor joint we leave on its own after we implanted whatever we put in there, it's a mixture of various cell sources. So it's a heterogeneity of things that get in there because the scaffolds are not sealed to one place or another. Cell migration has been shown if you use fibrin glue or if you leave it. Cell migration has been shown in collagen scaffolds, in porous scaffolds, as well in more dense scaffolds. So in the end, cells get into the scaffold and they will populate it and differentiate eventually. So it's a mixture of cells in the end, I believe.
Dear Philip, you are facilitating my answer because it's obvious that I believe in the paracrine action, and that's why I'm getting the adipose stem cells, but obviously I'm also counting on the fact that the interaction with the bone marrow stem cells will improve or enlarge the number of growth factors that can interact and improve the final workout of all the cells that are there and will give us the repair. We shall keep on the cells because Dragos Popescu is asking us for the patellar defect. Are we using cells or just microfracture? I think that from our presentation and our cases is quite evident, but please, let's go with another answer. Justus.
So just about the same as I do it in other defects, for example, at the condyles, I do the KY drilling, and this is where I gain the cells from. So I do not use any additional cells for defects at the patella. But I realized that Fabio did quite a lot of patella cases as presented in the in his studies or in his talks.
Yeah, absolutely, yes. Let's say that the beginning also of my experience there with was in open, little open cases. I do believe absolutely on the use of cells. I, as you, have stopped using micro or nano fracture. So I didn't want to say it at the beginning, but that's what obviously behind the idea. So we are all thinking of modifying the original technique and thinking to get our cells, adding our cells from outer sources. And this, I think, it's give us a great opportunity, and the results are following. So we can confirm that. Anything to add, Philip?
No here. So okay. I'm doing it the same way. I don't especially add cells if I tend to patella defects. I mean, of course, if you choose a two-step procedure and you opt for Macy, which has a long-standing history in Germany, for example, not in the US because you don't have it there for as long as we have it in Europe, then of course you use cells. But mostly, if we're talking about marrow stimulation, I don't add anything. I do the same to femoral defects as I do to retropatellar defects.
Okay. I want to go back to the questions of my friend Camilla, because she was stimulating us on the athletes. And this, I would like to share with all the participants something starting from the day one in the post-op. So what are you doing? Are you really keeping the patients out of weight bearing? Are you keeping the patient partial weight bearing? Let's make it easy. Let's start from the condyles, just to be on the same road show. Please, Justus, what are your first timings, so we can from there get to the sports regain?
So the surgical treatment is just about the same if there's an athlete or not in my hands. So in the OR, all patients are the same, but the rehabilitation process is totally different, for sure. But in all cases, I rest the leg for about 3 days, because using the fibrin glue, to me, it is important that the construct has some time to settle and get part of the superclot, and to be having the opportunity to withstand shear forces as well. So I start with resting the leg for about 3 days.
Then what happens? Not weight bearing or partial weight bearing?
If there are defects at the condyle, 6 weeks partial weight bearing.
Okay. Please, Philip.
Same for me, exactly.
That's interesting, because I think it's one of the first times that we all agree and we are all doing the same thing, and we are all going for partial, immediate, let's call it immediate partial weight bearing, instead of the, let's say, well-known not weight bearing for 6 weeks. So we are all going for partial weight bearing. That's a good comment. I'll bring you in, because also there's another interesting question for my friend Moses Cohen, always from Brazil, because he's substantially saying that in athletes, the Oates technique in his hands is giving very good results, and they are comparable results to the use of a membrane, and I should say maybe also in the timing. I believe in that, and I believe I agree completely with your comment, Moses, but I'll invite Philip to give us his thoughts about it. Do you believe in Oates? Well, I believe in the use of plugs. I believe also in the use of stem cells added to the plugs. So please, Philip.
I don't use it anymore because of the complications it may come with, like mismatch and stuff. But I absolutely agree, because if we're talking about Oates, we're primarily talking about fracture, about bone healing. So this is much faster than cartilage regeneration. So you may achieve a much faster full weight bearing than with any other product in the market, or any other technique in the market. But in the end, it's comparable to meniscus lesions, for example. If you have an elite soccer player that needs to get back on track quickly before a huge tournament, we have the European Championships in a few weeks, they receive meniscectomy, right? Because they are professional athletes and they need to get back on track. If you perform meniscal sutures, they're out partially or unloading for some weeks, and then have a slow return to sport eventually. And it's the same with cartilage regeneration. You need to perform something, and then Oates is pretty adequate to get them back on track quickly. And there, the Oates technique has its strengths, seriously. So
Moses, as you can see, also Philip agrees with you, and I also agree with you. Let's see what Justus has to add to your comment about the Oates technique.
So actually, this is one of the questions I would disagree.
Oh, that's nice.
Because in my hands, the Oates technique makes a lot of sense if you've got an osteochondral lesion. So I treat only osteochondral lesions with the Oates technique, but not the chondral lesions.
That's an interesting point. Even if I believe that at the end, we are always treating also the bone. And so I think that we are also always treating the osteochondral unit. So maybe I would share more the Moses point than yours this time.
It's okay for me.
That's nice for you. Thank you very much. Now I'll answer a question for my dear friend Douglas Sturgeon. He's in my committee in his IRS, and he's asking if I let the fluid, or if we let the fluid out before gluing the ammic membrane. The answer is quite obviously yes, especially with the arthroscopic technique. You need to have to pull out all the fluid in order to have a good joint that you can easily glue. Have you any comments on that? I don't know if there's any comment particular to do.
So I've got some experience with the fibrin glue in fluid conditions as well, in wet conditions as well, because in my hands it was always difficult to do it under dry conditions, because at the moment when I tried to get the membrane in, I always had some blood in front of the camera. So I did it under wet conditions, and there's some fibrin glues on the market who fix, although they're in wet condition.
Very good. Philip?
If I go for an arthroscopic approach, I use the wet medium just for one reason, because of the better phase separation you have. If you use fibrin glue, it's much easier to control what the fibrin glue does and where it goes in a fluid medium. If you do it under dry conditions, I find that it's sometimes like if you have the femoral condyle, then it starts to stick to the fat pad, it starts to stick everywhere, and you have complications to position the implant, position the membrane. So I also prefer to do it in a wet medium.
Okay, that's interesting. Always Doug is asking us if we are concerned about the violation of the subchondral bone. What would you answer? Philip, let's go.
In which context? This is the question.
It's just a general question. So I think that this takes us a little bit back to the idea of the drilling, and maybe on how far the debridement, maybe because we have spoken about the fact that we are not doing anymore the drilling, and we are doing just the debridement of the bed of the defect, especially Justus. So I think the question is referring there. What would you say, Justus?
Yeah, it's just, so you more or less gave my answer.
Okay.
I mean,
I agree.
I mean, in general, we are all concerned for the subchondral bone, right? But you need to have a compromise to, for example, recruit MSCs that have been shown, like in the concept of Kaplan, to act as signaling cells to induce chondrogenic differentiation in our cartilage fragments if you tend to go with minced and membrane. So there has to be some stimulus, right? And you need to create this stimulus. So this is for a price.
And now we have the top of the pops of the questions, because Abbasuddin is asking us, why is there pain in the knee joint? And that's nice. So I wanna find what type of answer are you gonna give? Go on, Philip.
This is some sort of a philosophic question, I fear. I mean, we all know this paper by Dye, for example, was scoped by his own, I think, son it was. I'm not sure, son or nephew. And he reported the most painful regions in the knee joint. So the patellofemoral compartment was found most painful, maybe because of receptor density. We don't know that, but pain, we have pain as a warning signal everywhere in the body. It tells us something isn't right, and maybe we should get it right. So this is difficult. This is really difficult to answer.
Yeah, it's a very tough question. So Justus, what would you say?
Yeah, to me as well, it is a difficult question, because actually I have a hard time to understand what the background of the question is. Probably because we're talking about cartilage. Maybe the question is if the pain derives from the cartilage lesions, but as we all know, there are no nerves in the cartilage, so it's probably it's not the reason. So I would think it's still open to debate where the pain comes from in the knee.
Yeah, maybe I should add that maybe a great part of the pain could come from, obviously, from the synovial tissue, because we all know that that's an important part of the inflammation contained there, the receptors and everything. And obviously also I could add that maybe the bone is the second responsible, another responsible of the pain in our joints. Obviously in the knee joints, it's a weight-bearing joint, so bone has its great importance.
I mean, there are so many different concepts out there. When I started training, almost in every scope, we resected half of the fat pad. We don't do that anymore because it may create a lot of post-surgical pain. I tend to stay away from the fat pad whenever I can. So the concepts change sometimes.
Yeah, because we can say that, as you know, who loves adipose stem cells as me can take out a piece of the fat pad, and you know there's published work on that, and use the fat pad as a source of stem cells. So obviously each tissue is loved from each one of us, and is also finds different uses. But I think that the most important sources of pain is certainly bone, synovial membrane, and so we'll try to move on, because we have a couple of questions. One is for me, because it's any regulatory issue about the use of adipose tissue. Well, the main regulatory issue was related to the homologous or non-homologous use of the adipose tissue. But I think that at the end, all the system, especially the Lipogen system, has received the FDA approval. So this, let's say, inquiry has been solved. And at this point of the story, the adipose graft is sincerely freely usable with no particular restriction, and there are already hundreds of papers on the use of adipose stem cells and adipose graft. But I've also a question for you, Philip, because there's a question about would you propose to collect the aligned cartilage from the intercondylar notch or non-weight bearing area to mince it and fill the cartilage defect? And I thank very much our friend Tiago Lazzaretti for the question.
Thank you to my dear friend Tiago. It would be nice to see you again in Berlin next year. So Tiago, what I found is that you can safely collect cartilage from the rim of the notch roof, but I would take caution of collecting, as you see it regularly, from the edge of the trochlea, because this may interfere with the patellofemoral joint. But I think the notch roof, as long as you resect it in a very, very thorough manner, is perfectly fine.
Okay, and we have just received the final question. We have several more, but it's impossible to answer everyone. They're asking until which patient's age has sense to use stem cells in the operations, and when they don't work anymore. That's very interesting. Well, I'll give you the answer starting from the adipose stem cells. It has been clearly stated that adipose stem cells suffer very, very low from the senescence of the cells. So they have been proved to work in whatever age. Obviously, there's a small decline in their function, but they are clearly stated to be possibly used in whatever age. About my indications, well, the general indication of cartilage repair, each one of us know that it's about until 55 or 60 years of age. But I think that each one of us will agree saying that it's not just a matter of age. It depends on the quality of the tissue, on the quality of the person, so on the biology of a biological age of the patient we have in front, and also on the quality of the tissues. So I think that this ending age of the indication is a little bit moving some years more. What do you think, Justus?
Actually, in one of our studies we divided the patients in 3 age groups, like young, middle age, and older patients up to 60 years. And we could see that in all groups, we had a significant increase of the functional outcome scores. So the younger ones did a little bit better than their older counterparts, but in all groups, we saw a significant increase. So going back to the question, probably even in patients up to 60 years, we have the chance that the cells are viable enough for cartilage repair.
That's good. Philip, any comments?
I would absolutely agree to what Justus just said. So,
okay. Paris Moncada just asked us something that maybe we already answered, because he's saying if microfracture, nanofracture, or no fracture at all to prepare the bone prior to scaffold application. So the answer is certainly the standard AMIC technique comes providing the idea of using microfracture. Most of the cartilage surgeons are now maybe believing in the fact that microfracture have did their time, at least in great part of the indications. There's maybe still valid as a first-time treatment in little defects and where maybe you cannot afford to go for more complicated or more costly procedures. So we believe in the debridement of the bed of the defect. Any further comment for you from my two friends there? No. Okay. Just final answer to Daniel, because I have to nearly go for conclusion. He's asking what about the analysis of the biopsy, of the quality of the biopsy. Justus already answered. As you saw, Dan, I analyzed what comes out from the adipose tissue, and I can confirm you it's going to be published very in the next months in our new journal of the ICRS Society. I confirm you that I saw the niche preservation, and I confirm you that the cells have very important the characteristics of the MSCs with all the receptors positivity, and I'll give you, if you want, further indications or details in private. So I please ask to get to my screen, because we need to move to the end of the meeting. I think we really had a very, very interesting session, and I want to deeply thank my good friends and colleagues that have made it possible, and also have made the discussion so interesting. But my principal thanks go to our friends of Gastric Society, because they made this event possible, and they are sustaining us with very up-to-date products that make this work go on and improve our results. I please invite all the participants. You will receive in the next hours the survey from the Office of the ICRS Society. Please, we count on your answers, and we want to see your interests in order for me, as the chairman of the Education Committee, to improve our work and be able to modify these events on the basis of what you're asking us. Going to these events, I want to please invite you to participate. As you can see, this is the second virtual convention that will be delivering on the 2nd and the 23rd of June. You can see all the ICRS top faculty will be there, and we also have great other faculty members from all over the world. As you can see, we shall have several modules. The first one will be Blood is the Lifetime, then The Magic is Red, Engineering is the Key, and most importantly, we'll finish thinking on what will be possibly the future in cartilage repair. Following this event, we shall have a very interesting talk with our past president, Daniel Saris, that will be hosted by Aaron Creech, and he will speak about the innovation once more driven by the patient needs. So the patient obviously has to be the center of all our work, of all our thoughts. And so please continue to be involved with the International Cartilage Regeneration and Joint Preservation Society events, and get ready to be back in person in Thessaloniki in October, and in the with our ICRS summit held from our president Tom Minas in November in Miami. So I want to thanks deeply ICRS Office, Gastric Society, Philip and Justus, and all of you that have been with us for this hour and a half meeting. Thank you very much, and see you in the next days. Bye-bye to you all.